Let's settle one of the biggest fertility questions I get: letrozole versus clomiphene. Both help you ovulate, but they work differently. Clomiphene, often called Clomid, is a selective estrogen receptor modulator. It blocks estrogen signals in your brain so your pituitary releases more FSH and LH, which can trigger ovulation. Letrozole, brand name Femara, is an aromatase inhibitor. It briefly lowers estrogen by blocking conversion. Your brain senses low estrogen, pushes FSH and LH. Same goal, different route. Dosing is simple. Clomiphene, usually 50 milligrams daily for 5 days, starting cycle day 3, 4, 5. If no ovulation, you may step up to 100-150 milligrams in later cycles. Letrozole, usually 2.55 milligrams daily for 5 days on cycle day 3, 7, sometimes increased to 7.5 milligrams if needed. Effectiveness. Let's be blunt. In people with PCOS, multiple large trials show letrozole yields higher ovulation, pregnancy, and live birth rates than clomiphene with fewer twins. That's why many guidelines now prefer letrozole first line for PCOS. If your cycles are irregular but not PCOS, both can work. Letrozole still often has a slight edge. If you already ovulate and the issue isn't ovulation, success rates with either drop. You and your doctor may consider moving faster to gonadotropins or IVF. Side effects, what you might feel. Clomiphene can cause hot flashes, mood swings, headaches, breast tenderness, and sometimes visual symptoms like blurring or spots. If that happens, stop and call your clinician. It can also thin the uterine lining and dry up cervical mucus, and it hangs around longer in your body. Letrozole tends to have fewer hot flashes and less impact on the uterine lining and mucus. Common effects are fatigue, dizziness, mild headaches, joint aches. It leaves your system quickly. Risks you actually care about. Multiple pregnancy. Clomiphene has a higher twin rate. Letrozole's is lower but not zero. Ovarian hyperstimulation is rare with either at standard doses. Birth defects. Large studies haven't shown increased risk with either when used correctly early in the cycle, but you should not take them if you're already pregnant. A pregnancy test before each cycle is standard. Who should consider what? PCOS, higher BMI and ovulation. Letrozole is usually first choice. Thin lining on prior cycles, dry cervical mucus, lean toward letrozole. Regular cycles with unexplained infertility either can be used, often paired with timed intercourse or intrauterine insemination. Letrozole may still offer fewer multiples. Monitoring matters. At minimum, use ovulation predictor kits and timed intercourse. Many clinics add ultrasound monitoring to check follicle growth and avoid too many follicles. If there's no ovulation after 3-4 dose increases or no pregnancy after about 3-6 ovulatory cycles, it's time to revisit the plan. Cost and access. Both are generics and inexpensive in most regions. Clomiphene is FDA approved for ovulation induction. Letrozole is widely used off-label with strong evidence. Bottom line, letrozole, higher live birth rates in PCOS, fewer multiples, gentler on the uterine lining. Clomiphene, time-tested, effective for many, but more anti-estrogen side effects and higher twin rates. The right pick depends on your diagnosis, age, partner's semen analysis, and your response on prior cycles. Talk to your clinician, get baseline labs and an ultrasound, check thyroid and prolactin, and make a plan you can stick with for a few cycles. You've got options and data to guide you.